Welcome everyone to Health for the World International Grand Rounds. Our Grand Round speaker today is Dr. Mark Liszewski. Mark is the Director of Division of Pediatric Imaging um, and Director of Montefiore Radiology Outpatient Imaging. He's also the Associate Program Director of Diagnostic Radiology Residency and the Associate Professor of Radiology at Department of Radiology at Montefiore Medical Center and the Children's Hospital at Montefiore at Albert Einstein College of Medicine. Mark received his Bachelor of Arts at the University of Minnesota and obtained his medical degree from Albert Einstein College of Medicine. After graduating, Mark began an internship in internal medicine at Beth East Royal Deaconess Medical Center, Howard Medical School. In 2012, he completed a residency in diagnostic radiology at Brigham and Women's Hospital, Howard Medical School, acting as a chief resident in 2010. In 2013, Mark completed a fellowship in pediatric radiology at Boston Children's Hospital, Howard Medical School, where he also acted as a chief fellow. Dr. Liszewski's research focuses on the radiological diagnosis of medical conditions affecting children. Um, Dr. Liszewski has particular interest in imaging of diseases of the pediatric chests, lungs and airway, ultrasound elastography in pediatric liver disease, and novel techniques in fluoroscopy. Mark has published many scientific articles and book chapters on imaging of pediatric, thoracic, gastrointestinal, and vascular diseases. He's also an assistant editor for the pediatric imaging section of the AJR and a reviewer for pediatric radiology. Mark is a member of several professional societies, including RSNA, Society of Pediatric Radiology, and the American College of Radiology. He's also a past member of APR Core Exam Committee, and he currently sits on the APR Online Learning Assessment Committee and the American College of Radiology Appropriateness Criteria Pediatric GI Rapid Response Steering Committee. Has been he has been recognized with several awards, including the Ralph Tier Award in Clinical Anatomy, the Golding Scholar Award, and was named to the AGR Reviewer Honor Roll. We are honored to have Mark today to give this wonderful grand rounds. Thank you so much, Mark, for doing this, and we really appreciate this. And you can start whenever you're ready.
Well, thank you very much for that very kind introduction. And I'm really pleased to have been invited to this talk. I'm really happy to have the opportunity to speak to so many of you from around the world. So I feel very privileged to be able to give this talk. So today I'm going to talk about neonatal lung disease. And it's a very important topic. And it's a very practical topic. So for anyone who is interpreting radiographs in newborns, it's very important that we have a good grasp of this topic because in the US, the leading cause for NICU admission is respiratory distress in neonates. So it's a very common scenario. So we really need to have a strong understanding when we're looking at these x-rays. So it can be a little tricky to make these diagnoses if we're not familiar with them. And if we don't have a nice approach to the imaging diagnosis of neonatal lung disease. But there's a method to the madness. So I'm going to go through that and present a nice way to sort of get to the right diagnosis. So when we are presented with a neonatal chest x-ray, we may see that it looks normal, or we may see that it looks abnormal. When it's abnormal, our first decision is going to be to decide what's the distribution of the finding. And that's going to go a long way in helping us to narrow our differential. So we can divide the neonatal lung diseases first into the diffuse lung diseases and the focal lung diseases. And then once we do that, we can go down a pathway of deciding which of those conditions it is. So I'm going to go through some of the different diffuse neonatal lung diseases in more detail, presenting a approach to the diagnosis. And then I'm also going to talk about some of the more common focal neonatal lung diseases as well. So we're going to start with the diffuse neonatal lung diseases. And when we are trying to decide which of these different conditions it is, we first have to decide whether we're looking at a patient who's preterm, if it's a patient who's a neonate who's born full term, or there are a few conditions that can occur in either scenario. But it's going to go a long way in helping narrow our differential if we can figure that out first. Because when we have a preterm neonate with a diffuse lung disease, the most common cause is going to be surfactant deficiency. And surfactant deficiency is a condition that we see very frequently. So it's very important that we have a good, solid understanding of the imaging findings in surfactant deficiency disorder. So I'm going to spend the most time talking about it because I think it's the most important. So first of all, what is surfactant deficiency disorder and what is surfactant? So surfactant, as we probably remember from medical school, is a lipoprotein that the main function is to reduce the surface tension of alveoli and therefore allows for the lungs to expand. Surfactant is produced by type 2 pneumocytes in the lungs, and it's fully matured, and the production of surfactant is fully ready to go by 35 weeks gestation. If a baby is born before that time, though, then the surfactant production is going to be less than is needed, and the molecular form of the surfactant is not going to be in its fully mature form. So when a baby is born premature, they're going to have not enough surfactant typically, and so they may develop this surfactant deficiency disorder. So then what happens? So the lungs basically are not going to have enough surfactant, so the alveoli are not going to be able to expand as much as they should. So the lungs will have decreased compliance. Now, in order to generate enough air exchange for adequate oxygenation, there's going to be things that are going to have to be done. So the baby is going to be pulling much higher negative intrathoracic pressures to try to pull air into the lungs. Also, if the baby needs mechanical ventilation or CPAP in order to obtain adequate oxygenation, there's going to have to be higher pressures that are going to get down into the alveoli. So those higher pressures will typically lead to alveolar injury. And when that alveolar injury occurs, fibrin and cellular debris can collect within the small airways and alveoli. So when that fibrin and cellular debris is looked at under a microscope, they're what's called hyaline membranes. And that's where the name hyaline membrane disease comes from. So, but when this happens, you get into a bit of a vicious cycle because the debris it impairs oxygenation, as well as atelectasis due to the decreased ability for the lungs to expand is also going to decrease oxygenation. And then we get into a bit of a vicious cycle where the decreased oxygenation is going to require us to be more aggressive with our ventilation management, and that may lead to even worsening of the alveolar injury. And so that's what happens in surfactant deficiency disorder. So what are the radiographic findings then in this condition, and what can we expect to see as radiologists? So there are a few classic findings that we're going to see. The first is a diffuse fine granular opacity, as we can see in this example. So this is a very typical appearance of surfactant deficiency disorder, where you can see that the lungs do not look normal. They have a hazy opacity, which is distributed diffusely throughout the lung. It's not focal, there's not some areas where it's more than other areas. It's a kind of a uniform pattern. And it's sometimes described as being granular because if you look at it very closely, it looks like there's kind of these little granular dots in there. And that is a very typical appearance for surfactant deficiency disorder on radiograph, but it's not the only appearance. Sometimes in a more severe case, we can have a much more extensive opacity. So as you can see here, there's a more diffuse pulmonary opacity with air bronchograms throughout all of the lungs. And this is a much more severe case. Now, another typical finding is going to be low lung volumes, but I put an asterisk on that. And the reason is because if we have just pure surfactant deficiency without any treatment, then it's very logical that the lung volumes are going to be low because there's decreased lung compliance, as I said, and so the lungs are not going to be able to expand as they normally would. However, in current practice where most patients who have significant respiratory distress are going to be immediately treated with endotracheal intubation, mechanical ventilation, or CPAP, the lung volumes may be artificially increased. So in reality, when we see radiographs of patients who have surfactant deficiency disorder, we can see normal lung volumes or even hyperinflated lungs. And that occurs because of the mechanical ventilation. Now, that kind of leads me to a little bit of a discussion about, the real world interpretation of surfactant deficiency disorder. And that is that we are often interpreting these radiographs in the setting of treatments that are ongoing. And those treatments really can alter the imaging appearance of surfactant deficiency disorder. And so as one example, I like to point out that when a child is born and they're born premature, it's usually no surprise to the neonatologists, that the baby is going to be born premature. And it's usually no surprise that when they're having respiratory distress when they're born, that it's going to be most likely due to surfactant deficiency disorder. So if we imagine what it's like to be in the delivery room when a preterm baby is born, what happens is the baby is born, they're known to be a premature baby, they have severe respiratory distress, and the neonatologist is going to jump into action immediately. They're not going to wait for an x-ray to be obtained. So typically, in a case of severe respiratory distress, they're going to place an endotracheal tube, and they're going to go ahead and administer exogenous surfactant to the lungs, often before we even get our first x-ray. So when we're looking at our first x-ray, we should keep in mind that that may be the case. We might be lucky enough to be told that this is post-surfactant therapy, in our little clinical indication that we're often provided when reading the x-ray. But sometimes we're not, they're busy trying to keep that baby breathing, so they might not be able to write in an accurate clinical history sometimes. But we have to know that when we're looking at the x-ray that might be the case. A clue can sometimes be that they're already intubated on the very first x-ray that's done in the delivery room, but it's not universal. Sometimes they'll put an endotracheal tube in and administer exogenous surfactant, and they'll take it out if the baby's respiratory status improves before the x-ray is done. So we might be interpreting a post-surfactant radiograph and not even know it. So it's important that we keep that in mind when we look at our x-rays, because in this case, we were lucky enough to know that it was a post-surfactant x-ray because they provided that information to us. And we also had a pre-surfactant x-ray in this case. And you can see that this is just how opacified the lungs were prior to the exogenous surfactant. So you can see that in this case, the lungs were quite significantly opacified. And then after the exogenous surfactant was given, there's a big improvement in the aeration of the lungs. The treatment can also cause some other findings that we might see. So this is an example of asymmetric distribution of surfactant that was administered right after birth. And so you can see that the right lung is much better aerated, much better expanded, and the left lung is completely opacified. And that's because the exogenous surfactant made its way all into the right lung and not into the left lung. So, we can imagine why this would happen, right? Sometimes when we look at x-rays, we'll see that the endotracheal tube is in one of the main bronchi, more typically the right than in the left, but it can occur in either main bronchus. And if that endotracheal tube happened to be in the right main bronchus at the time that the exogenous surfactant was administered, we might end up with this type of a scenario. Now, when this particular scenario occurs, it can really be a challenge because now that the right lung is going to be much more compliant than the left lung, all the air that's coming in through the endotracheal tube is going to preferentially go into the right lung, and it's going to kind of shunt away from the left lung. Of course, the next step in treatment will be to try to administer exogenous surfactant into the left lung, by placing the patient on their left side down, or having them turn several times after the next dose of exogenous surfactant is administered. But it can be a very persistent problem because the air is going to preferentially go into that right lung. And so when the volume of air is set on the ventilator, it's all going to go into one lung instead of two lungs. The alveolar injury can be worse because you're basically aerating one lung instead of two lungs. So it can be a very tricky problem. Another way that the surfactant may alter the imaging appearance is that occasionally the surfactant can get down into the acini and alveoli and cause them to expand quite a bit. So you can see that, like in this case, there's these little small round lucencies in the lower lobes. And that is actually due to little hyperexpanded acini that got surfactant. The reason it can be a little bit tricky is because it can occasionally mimic another condition, which is called pulmonary interstitial emphysema, which I'm going to talk about later. But the way that we can usually sort that out is by considering the clinical scenario a bit, sometimes by calling our colleagues in the neonatal intensive care unit. Because when it's this pattern, when it's just hyperexpanded alveoli due to the surfactant, usually the patient is actually doing much better than they were doing before the surfactant was given. Whereas if it's a case of pulmonary interstitial emphysema, it's typically accompanied by a worsening of the respiratory status. Now, when we're looking at patients who have surfactant deficiency disorder and we're doing x-rays, another really key important thing that we're doing, perhaps the most important thing that we're doing, is looking out for complications. So like I mentioned, the neonatologists are not surprised when a newborn preterm baby has surfactant deficiency. They are expecting it. And when we're doing serial x-rays and we see the findings of surfactant deficiency, it's not going to be a surprise. But the reason that they're doing the serial x-rays isn't to continue to document the findings of surfactant deficiency. It's to look out for complications that can occur with surfactant deficiency. So the two main groups of complications that we're looking out for on x-ray are going to be air leak phenomena, and then different scenarios that can cause acute worsening opacification of the lungs. So air leak phenomena are basically those conditions where air goes where it's not supposed to go. So that's pneumothorax, where air is going into the pleural space, air going to the mediastinum, with pneumomediastinum, and then pulmonary interstitial emphysema, which is a condition that pretty much exclusively happens in the neonate, but it's a similar phenomenon where the air dissects into the pulmonary interstitium. So you can see on this example that I have here, you can see that there's a large left-sided pneumothorax that you can see here, and you can see that this is, a child that was born premature and is at day of life 2. When you look very closely, you can also see that there are some small, round, and branching lucencies in the left lung that don't conform to the shape of the air bronchograms, and that is an example of some pulmonary interstitial emphysema as well. You can see that on this example, we can see another example of pulmonary interstitial emphysema. And in this case, there is no pneumothorax, but you can see that these lucencies here are branching and a little bubbly lucencies, and they don't quite look like air bronchograms. They don't look like they fit the shape of the normal airways. And you also notice that there's more lucency on this side than on this side. So those are the typical findings of air dissecting into the pulmonary interstitium or pulmonary interstitial emphysema. It can be a subtle finding, so it's something that you have to really look out for, but those are the typical, that's the typical appearance. Now, the other group of conditions is when there's an acute worsening opacification of the lungs. So in uncomplicated surfactant deficiency disorder that responds to treatment, we should have a gradual improvement in the hazy pulmonary opacities. But when there is an acute worsening of the aeration of the lungs or acute worsening opacity in the lungs, we have to think that there's something else at play than just pure surfactant deficiency disorder. So in this case, you can see that at day of life 1, we had an imaging appearance that was pretty typical for surfactant deficiency disorder. But then at day of life 3, there was an acute opacification of the lungs. When we see an acute opacification in that scenario, we should consider a few different conditions. In this case, this child was having blood coming from their endotracheal tube, and this is a case of diffuse alveolar hemorrhage that occurred due to diffuse alveolar injury. Other reasons that you might get an acute worsening of opacity is in cases of pulmonary edema, such as in patients who have congenital heart disease or patent ductus arteriosus, or a more kind of common reason to get an acute worsening opacity is from atelectasis. But that's important because often it will be something that can be treated or addressed with a change in management. For example, if the endotracheal tube is placed in one of the main bronchi, we may see that on the x-ray and see that there's atelectasis in one of the lungs. We make a call to the neonatologists and they're able to adjust the endotracheal tube and fix the atelectasis. Or if there's worsening atelectasis overall, we may be able to let the neonatologists know and they may be able to alter their ventilation settings to help improve the aeration. All right, so that's all I have for the surfactant deficiency, and we'll move on to some of the other diffuse neonatal lung diseases that can occur in the full term neonate. So the first one I'm going to talk about is retained fetal fluid. So retained fetal fluid is a condition that occurs when there is fetal fluid that is still in the lung at the time of birth. So, in utero, the fetus is breathing in amniotic fluid, breathing in the fluid from the amnion, and the lungs are just completely filled with fetal lung fluid. But when born, there's a transition where that fluid clears and there's obviously air that goes into the lungs. Now, in the normal childbirth, it's a fairly long process, and there's enough time for that transition to occur. But in cases where there's either a very fast precipitous labor or in cases of a cesarean section, that process may not have time to fully occur, so that we may end up having some retained fetal fluid in the lung once the child is born. So the imaging findings of that condition basically reflect the underlying way that fetal lung fluid is cleared. So a portion of the fetal lung fluid is cleared by coughing, but the majority of the fluid is cleared through the pulmonary lymphatics. So when we see an X-ray finding that accompanies the retained fetal fluid, we basically see a pattern that looks like the pulmonary lymphatic distribution in the lungs. So the pulmonary lymphatics, as we know, basically live along the bronchovascular bundles in the interlobular septa of the pulmonary interstitium and in the subpleural spaces. So on an X-ray, what we're going to see in this condition, we're going to see some linear, diffusely distributed opacities, which reflect the pulmonary lymphatics along the bronchovascular bundles and within the interlobular septa. And then we're going to see thickening of the minor fissure, which reflects the pulmonary lymphatics that are in the subpleural space. Now, retained fetal fluid is going to typically clear within the first 48 to 72 hours of life. So if we're entertaining this diagnosis, but we see that the findings persist beyond that time, then we probably want to consider alternative diagnoses. Also, the symptoms are typically fairly mild. And so if a patient needs more advanced airway support like intubation or CPAP, we may consider alternative diagnoses. All right, so the next diffuse lung disease that occurs in full-term infants is meconium aspiration syndrome. So meconium aspiration syndrome occurs when there's passage of meconium while in utero, and there's aspiration of that meconium into the lungs. So this occurs most commonly in full term, or even more commonly in babies that are post dates. And the issue is that meconium, for anybody that's ever seen it, or had a baby, or worked with a baby and seen that first meconium, it's a very thick, tarry material. It's very sticky, and it's full of a lot of chemicals that can be a really bad irritant to the lung. So when if it's aspirated into the lungs, it can cause a lot of problems with pneumonitis. So what we see on the X-ray is the manifestation of that pneumonitis. The appearance, it has a different appearance than some of the other diffuse lung diseases that I showed so far. And the classic way it's described is asymmetric, ropey, or coarse opacities. The reason for that is because the meconium gets down into the small airways. It causes a local inflammatory reaction. It's going to cause atelectasis in all the airways distal. It may, in some spots, cause a ball valve mechanism where there's air trapping. So we're going to get alternating areas of hyperinflation and atelectasis. In addition, a lot of inflammatory reaction. So we get this typical appearance. When there is meconium aspiration syndrome, there is a fairly high incidence of pneumothorax. So between 10 and 40% of the time, babies will develop a pneumothorax. So when interpreting a radiograph in a child that has meconium aspiration syndrome, it's very important that we look really closely for that pneumothorax because we don't want to miss it. Also, pleural effusion can occur in a minority of cases, about 10 to 20% of the time. So that might be something we want to look for as well. All right, so I'm going to get on to now some of the other diffuse lung disorders that are less common, but important to know that they exist. And so the first group I'm going to talk about is the diffuse developmental disorders. Now, these are a very rare group of conditions, but they can cause diffuse lung disease and pretty significant respiratory distress. So these conditions include acinar dysplasia, congenital alveolar dysplasia, and alveolar capillary dysplasia with misalignment of the pulmonary veins. And there are very serious conditions that unfortunately have a mortality rate of nearly 100% by 2 months of age. And the imaging findings are very non-specific, unfortunately. They look a lot like some of the other diffuse lung diseases where we see low lung volumes and diffuse hazy pulmonary opacity. But these conditions are due to an underlying abnormality in the primary development of the lung that leads to this severe progressive respiratory failure. The way that these are diagnosed in reality is that we're going to see this diffuse lung disease pattern on X-ray. We're going to entertain all the other more common diagnoses. And when those other common diagnoses are ruled out, then we will begin to consider these more rare conditions. The way that this condition is actually diagnosed is with biopsy, and under the microscope, the diagnosis can be made. So occasionally when we have a newborn that has persistent respiratory distress and we have no other cause, biopsy may be performed in part of that workup to look for these much more rare conditions. Another group of conditions that are also very rare are the congenital surfactant dysfunction disorders. And in these conditions, there's a genetic mutation that is involved in a gene that's involved in the production or function of surfactant. So there are a whole group of different genes that can be mutated and cause one of these conditions. They include surfactant protein B, surfactant protein C, ATP binding and cassette transporter protein, thyroid transcription factor, granulocyte macrophage colony stimulating factor. And a mutation in any of those genes is going to lead to the end effect that dysfunctional surfactant is going to collect in the airways and within the alveoli, and it's not going to be able to be cleared as rapidly as it should. And so as that surfactant collects, it's going to interfere with oxygenation. This is similar to the other conditions that I talked about where it's a much more rare condition. And the way that the diagnosis is usually reached is that we entertain all more common diagnoses, and then we go on to look for the more rare conditions. These particular conditions are diagnosed with genetic analysis, genetic testing, and one of these gene mutations is identified. Another more rare condition that can cause diffuse lung disease is congenital pulmonary lymphadectasia. This is a condition which is characterized by dilation of the pulmonary lymphatics and chylous pleural effusions. The imaging findings are also a bit nonspecific. They're going to basically reflect findings of pulmonary interstitial opacities reflecting an enlargement of the pulmonary lymphatics. And we may see pleural effusions on X-ray or on CT reflecting those chylous pleural effusions. This condition tends to occur in conjunction with a few genetic syndromes, including trisomy 21 and Noonan syndrome, and can occur in conjunction with congenital heart disease. Now, there are two other diffuse lung diseases in the neonate that can occur in either preterm or full-term neonates, and the first is the group of alveolar growth disorders. So alveolar growth disorders are a group of different conditions that are basically conditions that are due to a superimposed process that affects lung development. In other words, in these conditions, if the lung was allowed to develop on its own without one of these external factors, it would develop normally, but there is some superimposed process that affects the lung development and makes it altered. So the most common examples that we encounter are chronic lung disease of prematurity, which also has the name bronchopulmonary dysplasia. Secondary pulmonary hypoplasia is another one that falls into this category. And then there are a few genetic or chromosomal defects that can also lead to alveolar growth disorder. I'm going to spend a little time on chronic lung disease of prematurity because it's another one of those common conditions that it's very important that we have a strong understanding of. So chronic lung disease of prematurity is basically the result of alveolar damage that occurs in patients who have surfactant deficiency disorder. So as I mentioned, patients who have surfactant deficiency disorder often need high positive pressure ventilation, higher concentration oxygen, and other measures to try to keep their oxygenation. And these different external factors can lead to lung injury, and that lung injury will manifest as this condition, which is chronic lung disease of prematurity. Now, in 1967, this was described by Northway, and there was a 4-stage process that was described about the development of what was called at that time bronchopulmonary dysplasia. Basically, it went from the first stages, which is the findings of classic surfactant deficiency disorder, to a next stage, which was an acute opacification of the lungs, followed by a reparative phase in stages 3 and 4, where those opacities were replaced by cyst-like lucencies and areas of fibrosis. In modern practice, the treatments that we now do that we were not doing in 1967 have altered some of the imaging findings in chronic lung disease of prematurity, such that we don't always progress through the 4 stages. However, when a patient goes on to develop chronic lung disease of prematurity, very frequently the end result is similar as stage 4, as described by Northway, where we see areas of linear fibrosis, pulmonary hyperinflation, and atelectasis. One of the other disorders that can occur that I mentioned was secondary pulmonary hypoplasia. So secondary pulmonary hypoplasia is basically a condition where the lung is not allowed to grow because of an external factor that's not allowing it to expand normally. So one of the more common scenarios that we see this in is in congenital diaphragmatic hernia. So you can see in this example, there's a very large right-sided congenital diaphragmatic hernia, where this is all bowel that's herniated up into the right thorax. And then this is the right lung, and that right lung is not going to be able to develop normally. And so even after the hernia is repaired and the bowel is brought down back into the abdomen, that lung is going to have pulmonary hypoplasia that's going to lead to significant continued symptoms even after the hernia is repaired. So this can occur in other conditions, so such as like oligohydramnios, where the whole thorax is small because there's a small amount of amniotic fluid in utero, or in some skeletal dysplasias where the thorax is not allowed to be large enough. A more rare condition that falls into this category is the genetic causes for alveolar growth disorder. So trisomy 21 is one of them, where about 36% of patients who have trisomy 21 have underlying lung disease, and it's typically has this appearance of small cystic lucencies in a subpleural distribution. This condition usually we don't diagnose in the neonatal period, and it's usually diagnosed later in life, typically with CT. The last diffuse congenital lung disease that I'm talking about is not really a lung disease, but it's actually a cardiac disease, which is vascular congestion causing abnormality in the lungs on X-ray. And so this condition occurs with congenital heart disease. It may occur with patent ductus arteriosus, and it's basically pulmonary vascular congestion where we see increased pulmonary vascular markings. We may see interstitial opacities, so on X-ray that'll manifest as curly B lines, or on CT we may see interlobular septal thickening, which reflects the interstitial edema. And here we can see on CT, this is thickening of the interlobular septa, outlining the secondary pulmonary lobule, which are these hexagonal shaped structures here. Okay, so that's all that I have for the discussion of the diffuse neonatal lung diseases. And I'm going to move on now to a description of some of the focal lung diseases. These occur less frequently, but it's important that we have a bit of a working understanding of them so that we know how to approach one of these lesions when we see them. So the focal neonatal lung diseases really are the congenital pulmonary malformations for the most part. So congenital pulmonary malformations are congenital lesions that have to do with a developmental disorder that affects either the lung parenchyma, the vasculature of the lung, or a combination thereof. There are a group of different congenital pulmonary malformations that include the conditions that I have listed here. I'm not going to talk about every single one of them. In the interest of time, I'll be talking just about the more common conditions. The development of these congenital lung lesions is basically due to a combination of factors. It can be due to defective foregut budding during embryologic development. can be due to a congenital obstruction of the airway, leading to secondary development of these lesions. It can be due to a primary abnormality in the vascular supply to the lung. And it can be caused by an underlying genetic reason, which in many cases there is a genetic link. The bottom line is that when we look at these lesions, it's important that we consider whether they're affecting the lung parenchyma, the pulmonary artery, the arterial supply, or the venous drainage, or a combination thereof. And when we characterize these lesions, we want to look closely at those three factors because those are going to be the main ways that we're going to be able to differentiate the diagnosis and also provide our surgical colleagues with the information that they need before managing these cases. The first focal neonatal lesion I'm going to talk about is congenital lobar overinflation. So this is a condition where, just like the name says, there's a congenital overinflation of one or more lobes of the lung. And so why does that happen? Well, it happens because there's air trapping that occurs in that lobe of the lung where air is allowed in, but not allowed out. And that can be because of either an intrinsic or extrinsic bronchial narrowing that causes a ball valve mechanism. And when this occurs, the newborns and the neonates are going to typically present with respiratory distress. It may not cause respiratory distress right away, but it may cause a progressive respiratory distress that occurs as that lobe of the lung continues to hyperexpand. So this is an example in a newborn where we can see on the first X-ray, there's this very subtle increased lucency in the left upper lobe. But then over time, that lobe gets more and more expanded and more loosened. And that's very typical for congenital lobar overinflation. Sometimes the very first X-ray may show a greater opacity in the affected lobe. That can be because the fetal lung fluid can actually get trapped inside of the affected lobe, and it can have delayed clearance. And then once it's cleared, then it's replaced by air, and then we see findings like on these pictures. Now, the overinflation can become quite significant. So as you can see in this case, the left upper lobe became quite enlarged, such that there's mediastinal shift and significant mass effect on the heart. And this is very important because that significant mass effect can cause severe symptoms and can be life-threatening. And therefore, when congenital lobar overinflation is causing symptoms, the treatment is lobectomy. In some cases, if it's a mild case that might be incidentally noted, a conservative approach may be appropriate, but we always want to be really careful in congenital lobar overinflation because of that potential for progressive hyperexpansion, such that if there is any signs of symptoms, the typical treatment is going to be with lobectomy. The next focal neonatal lung disease I'm going to talk about is congenital pulmonary airway malformation. So this goes by the name cpam often, and it used to be called congenital cystic adenomatoid malformation, which was CCAM, but the name has been changed to more accurately reflect the condition and what's really going on. It's basically a group of congenital cystic and non-cystic lung lesions that are characterized by overgrowth of the primary bronchioles, which are in communication with an abnormal bronchial tree that lacks cartilage. The majority of CPAMs are lesions that are isolated to the lung parenchyma and do not have any abnormality in the pulmonary vasculature. However, there's a group of hybrid lesions where we may see congenital pulmonary airway malformation in conjunction with abnormal vasculature. So it's important that we're aware of that. There are 5 different types of congenital pulmonary airway malformation. These were described by Stoker, and type 0 is something that we don't see because it's incompatible with life. It's a diffuse acinar dysgenesis. But types 1 through 4, we may see. So type 1 is characterized by a large cyst, which is larger than 2 centimeters in size and typically has a thin wall. So on this X-ray that was done in a newborn, we can see that there's a large cyst, which is filled with air in the right upper lobe, and it has a thin wall. And then we do a CT. We do that CT with contrast because we want to look to see if there's any abnormal vasculature. In this case, there was no abnormal vasculature and there was just this cyst. So we made the diagnosis of a type 1 cpam. Now, type 2 cpam is similar. We see a lucent lesion in the right lower lobe, but in that lesion, it's not just one cyst, it's multiple small cysts if we look closely. A CT was done, and we can see that the cysts are smaller than 2 centimeters, and there are numerous. So this is congenital, this is compatible with a type 2 congenital pulmonary airway malformation. This lesion is the type 3, and that is a solid lesion within the lung. So in this case, the X-ray was normal, but we knew that this lesion was present based on prenatal sonogram. So a CTA was performed to evaluate the lesion and evaluate the pulmonary vasculature to see if there was an associated vascular anomaly. And you can see when we look at the lesion, it looks like a solid mass in the left lower lobe. And to our eyes on imaging, it's going to look solid. To the surgeon's eyes, when they take it out, it's going to look solid. But to the pathologist, when they look at it under the microscope, it's actually composed of numerous tiny little cysts. So it is also a cystic lung lesion, but to us, it's going to look like a solid lesion. So it's important that we remember that when we are presented with a solid lesion in the lung. The last type is type 4, which is a more extensive cystic lung disease, and that's due to basically air-filled cysts that arise from the distal acini. These conditions, this condition is a lot more extensive usually and may be associated with mass effect. All right, so then we're going to talk next about bronchopulmonary sequestration. And unlike some of the other conditions that I started with, this one involves an abnormality of the vasculature of the lung. So there are two different types of bronchopulmonary sequestration. Either type is defined as non-functioning lung tissue that's not in communication with the rest of the lung. So it's sort of isolated lung. When it's intralobar sequestration, that portion of the isolated lung shares a pleural covering with the rest of the lung. When it's extralobar sequestration, that part of the isolated lung has its own pleural covering. Both types have an arterial supply arising from a systemic artery, usually a branch of the thoracic aorta or upper abdominal aorta. But there's a difference between intralobar and extralobar sequestration when it comes to the venous drainage. Intralobar sequestrations typically have a venous drainage to the pulmonary vein, and extralobar sequestrations typically have venous drainage to a systemic vein. Both occur more commonly in the lower lobes, and both occur more commonly on the left than on the right. Extralobar sequestrations can occur outside of the thorax. They may occur in the upper abdomen, in the pericardium, in the mediastinum. So that's also important to be aware of. This is an example of extralobar sequestration where we could see an opacity in the left lower lobe. And when we look with CTA, we can see that the artery feeding that lesion arises from the descending thoracic aorta, and the venous drainage is from a branch of the azygous vein, which we can see on this 3D reformation here. This is an example of an intralobar sequestration where the X-ray looked normal, but we knew about its presence from fetal ultrasound, and we can see that there's a systemic artery coming from the descending thoracic aorta and a venous drainage going into the pulmonary vein, as we can see in this 3D reformation. All All right, and then the last condition I'm going to talk about is bronchogenic cyst. Bronchogenic cysts are conditions that are isolated to the lung parenchyma and not part of the vascular supply. And it's a developmental anomaly that results from defective budding or branching of the tracheal bronchial tree during embryologic development. They're really considered in conjunction with other types of congenital cysts, really a group of cysts called the foregut duplication cysts, which are comprised of either esophageal duplication cysts, bronchogenic cysts, or neuroenteric cysts. Bronchogenic cysts most commonly are located within the mediastinum, about 70% of the time, and then the remainder occur out in the lung parenchyma. When they occur in the mediastinum, they most often do not communicate with the tracheobronchial tree and therefore are just fluid-filled cysts. But when they are in the lung parenchyma, in the minority of cases, they more typically do communicate with the tracheobronchial tree, and then they often contain air and variable amounts of fluid. So this is an example in an older child of a bronchogenic cyst that we can see in a typical subcarinal location. And you can see on CT that the cyst has fluid, is comprised of fluid density. And on this T2 weighted MRI image, it's characterized by fluid, which is hyperintense on that image. When they occur out in the lung parenchyma, they are more prone to superinfection. So, and that occurs because of that communication with the tracheobronchial tree. So this is a case of a bronchogenic cyst in the right lower lobe, where there's thick, irregular enhancement of the wall due to superinfection. These can be managed, in the setting of infection with aspiration if needed, but then the definitive management is with resection when they are symptomatic. All right, so that's the end of what I wanted to talk about. So in conclusion, some keys to approaching neonatal lung disease involve deciding whether it's a diffuse process or a focal process, and then going through the pattern that I described, trying to decide which of the conditions it is using that systematic approach. All right, so thanks a lot, and happy to take questions.
Thank you very much, Dr. Liszewski. It was very pleasant. I thoroughly enjoyed it, and I guess I can speak for everyone that we have learned a lot today from you. So I would like to speak the questions for you. Our first question is, how do you assess a lung focal hyperinflation in an overexposed radiograph?
Okay, so if it's overexposed, well, in like a modern PACS situation, you can often, window and level to try to kind of get through that issue of an overexposed radiograph. Ultimately, I mean, if you have a very poorly done radiograph that's really overexposed, you might be stuck and you might have to repeat the X-ray. So I think that we try to make our best assessment, comparing what we think the affected lung is to the unaffected lung, looking at the location of the diaphragms to see if the lungs look like they're hyperexpanded. But at the end of the day, if you have a really poorly done X-ray, you might be stuck having to repeat it. Oh, sorry, I'm having trouble hearing you.
So next question is, how often can I request the X-ray to avoid unnecessary radiation? And how can we avoid this unnecessary exposure?
Sorry, I couldn't hear the whole question. You mind just saying it one more time?
Can you hear me now?
Yeah, I can hear you better.
So how can we avoid unnecessary exposure of radiation to the lung? How often do you request the X-ray to avoid this?
So, I think that it's important that we always be very considerate of, radiation exposure. And of course, as pediatric radiologists, we're very focused on only doing X-rays when they're needed and only minimizing our radiation exposure. But I want to point out that doing an appropriately performed X-ray has a very, very low X-ray dose. And in all the conditions that I was describing today, these are very serious medical conditions. So, doing X-rays in these conditions is indicated, right? So we want to be careful to not do unindicated X-rays and not needlessly expose patients to radiation. But when we have a seriously ill child, as in all the conditions that we talked about here, then doing X-rays is appropriate. So when we talk about like the scenario that I talked a lot about today about surfactant deficiency disorder, and a child who's in very serious illness, very serious respiratory distress, the radiographs are going to be performed at least daily and maybe more frequently, because it's very important. It can change the management. We may need to alter the position of an endotracheal tube. We may need to change our management based on those X-rays, and it could be life or death for that baby. So in that scenario, doing frequent X-rays is totally indicated. Now, another scenario where a patient's totally clinically stable and there's no reason, then of course, yes, we would want to limit those X-rays. But I always like to point out that we want to be very mindful of X-rays, limiting the X-ray exposure. But we also want to remember that we provide a very important service to these patients, and we can be the difference of life and death in many cases. So when an X-ray is clinically indicated, we want those X-rays to be done.
Is it possible to differentiate intralobar and extralobar sequestration?
I'm really sorry, but I'm having trouble hearing you again. Not so well. I'm sorry.
So is it possible for you to hear now, or can you read the question?
Okay, I can hear you better. Let me try to open up the Q&A.
If you're hearing, then I can speak for you.
Okay, yeah, I can hear you better now.
So is it possible to differentiate between intralobar and extralobar sequestration imaging?
So, I mean, the ultimate diagnosis is always made on pathology, but the biggest clue for our imaging diagnosis is going to be looking at the venous drainage. So all bronchopulmonary sequestration, by definition, has a arterial supply from a systemic artery. So both intralobar or extralobar, both are going to have a systemic artery. That's how you make the diagnosis of bronchopulmonary sequestration. But then it's the venous drainage that's going to allow you to start to suggest whether it's intralobar or extralobar. If the venous drainage is going to the pulmonary vein, that's suggestive of intralobar. If it's going to a systemic vein, it's suggestive of extralobar. Now, if it's a case where it's in the abdomen, for example, like it's a lesion that's below the diaphragm, then it's very clear that that's extralobar pulmonary sequestration. So there are some situations where it's also very obvious for other reasons.
So, do you consider using ultrasound to assess bronchopulmonary cysts?
So we can. Certainly we can use ultrasound for that. The main way we use ultrasound, of course, is in the prenatal ultrasound. So very typically, in practice, at least in the United States, babies are getting prenatal ultrasound routinely. And very typically, these diagnoses are known to us before the baby's even born. So that's the most common way that ultrasound is playing a big role. But then, yes, once the baby's born, then we can use ultrasound. So one scenario that'll occur is sometimes we'll know of a lesion based on prenatal imaging, and then we may, with ultrasound, go to look at that lesion, if it's a cystic lesion, for example. The case of the bronchopulmonary sequestration, if it's known that there's a congenital lung lesion on prenatal imaging, we may use ultrasound to look for the arterial supply. Now, it can be limited, especially in cases of bronchopulmonary sequestration, where once the lung is aerated, it can be very difficult to see the vascular supply because the air is going to cause shadowing that's going to make it impossible for us to see. But we can sometimes see it, and we usually do try with ultrasound first. But especially when a patient's going to be going on to surgery for resection, we very typically will do imaging with either MRI or CT to map out the vasculature, map out all the adjacent structures so that our surgical colleagues sort of know what they're getting into before they go and do the resection.
Thank you very much for answering. I want to let you know that we have attendees from across the world. We have almost 150 attendees right now. And I would like to mention they are sending you greetings from Bhutan, Mexico, Tanzania, Belgium, Turkey, Philippines, Zambia, Ghana, Burundi, and so many places more. Because of time constraints, I can't mention the names right now. We just wanted to say thank you very much for this. Unfortunately, Dr. Rehani had to leave perhaps for a procedure, but she wanted me to let you know how thankful she was. Thank you once again for this wonderful presentation today. And to our audiences, thank you very much for joining. And the presentation will be available on our YouTube channel. And we look forward to having you all again on our next International Grand Rounds. Thank you very much, everyone, for joining today. Thank you very much, Dr. Liszewski, again.
Thank you very much. It's a privilege to do this. I really appreciate the invitation. And thanks to everybody for listening.